So the answer to question 1, delusion is a disorder of, correct answer to this is option A, that is thought. Now let us discuss, answer is A. Now let us discuss various disorders of thought. Now thought disorders are characterized under 4 parameters. The first is flow or stream, second is form, third is content, and fourth is possession. Now let us discuss about the first, flow. Now the thought disorders of flow or stream are again further characterized into disorders of tempo, and second is disorder of continuity. Now disorders of tempo include when the tempo is increased, that is, for example, flight of ideas seen in mania. Then again another example of increased flow, increased tempo is prolixity, which is seen in hypomania. Now the flow may be decreased, the tempo may be decreased, and this is, example of this is inhibition or retardation of thinking. Which is seen in depression. Now another important and a controversial thing is circumstantiality. Now where does circumstantiality lies? Now some books say it is a disorder of form, but according to the major books of psychopathology including Fish, and Sims psychopathology, circumstantiality is the disorder of flow. In this, the person gives trivial information before reaching to the goal, and it may be seen in epileptic personality changes and in other organic conditions. So an important thing to remember is that circumstantiality is a disorder of flow. Now in continuity, in the disorder of continuity, various examples are, first is perseveration, which is generally considered as a sign of organic condition. And another important disorder of continuity is thought block, which is seen in schizophrenia. So these were the disorders of flow. Then coming to disorders of form, some of the important examples include loosening of association, then derailment, then tangentiality. Here the goal is not reached. The person goes tangent to the topic and never returns back to the goal. So the goal is not reached. Then neologism, Then there is talking past the point, also known as verbigeration, verbaridon. Then there is verbigeration, also known as word salad. So these are some of the important disorders of form. Now let us come to the important disorder of content of thought. Now in the disorders of content of thought, the example is delusion. Now let us discuss in detail about delusion. Now delusion is a false, firm, fixed idea or belief which is out of keeping with persons, social, cultural and educational background, and it is held with extraordinary conviction and subjective certainty. Now that is, the belief is so strong that even if other people try to convince the person is not convinced, and he is very particular, and the belief is very fixed. Now some of the important examples of delusions are, the most common is the delusion of persecution. In this, the person believes that other people are trying to harm him. It may be the family members, or it may be in the people around, or maybe the colleagues at work. Then second is delusion of reference. Here the person believes that people are talking about him or her and making gestures which is in reference to him. Then third is delusion of grandiosity. Here the person believes that he has supernatural powers, he knows very high people, and this belief is very strong. Others are delusion of guilt. Then there is nihilistic delusion or delusion of negation. Here the person believes that I do not exist, the world around do not exist. And one of the important example is the Cotard syndrome, which is again an important MCQ. Then a few important ones are de Clerambault's syndrome, also known as delusion of love or erotomania. Here the person believes that someone of very high stature in society or financially is deeply in love with that person, although the victim has not done anything to gain attraction. Then another important example is Othello syndrome, also known as delusion of infidelity or morbid jealousy. Here the person is having a belief, delusional belief, that the spouse, his or her spouse or partner, is infidel. This is importantly seen in alcohol use. With chronic use may develop delusion of infidelity. Again an important MCQ. Now let us come back to the fourth type of disorder of thought, that is possession of thought. Here the person, there is a disorder that the thought possessed by the person is not his own. Now, important thing in this is disorders of possession and frequently asked MCQs are, first the example is obsessions and compulsions. Now, although the person in obsessions says that the thoughts are actually his own thought, but these are unacceptable thoughts. Unacceptable thoughts, and they are also resisted by the person. Generally unsuccessfully, at least one of them is unsuccessfully resisted by the person. Hence, these, although the person's own thought, but because of the unacceptable nature of the thoughts and being resisted by the person, these are discussed under possession of thought. These thoughts are generally ego dystonic. Important, that is, they are not in tune with the ego, as unlike delusion where the person is very much convinced that these are real thoughts. Here the person reports that these are unacceptable thoughts, and although this is not true, but still these thoughts are occurring. Another important example, second important example is the thought alienation or passivity of thought. Here examples are thought insertion, that is the person believes that someone is inserting thought in the person, thought withdrawal, that someone is withdrawing the thoughts, and thought broadcast, that his or her thoughts are being broadcasted out in the world. Important, and they may all be seen in schizophrenia. Important. So this was about the disorders of thought. Now let us discuss the next question. True about hallucination. The correct answer is answer D. They are false perception. Answer is D. They are false perception in absence of a stimulus. Now, let us discuss in brief about the disorders of perception. Now, two important disorders of our interest are, first is illusion and second is hallucinations. Now, illusions are actually misinterpretation of a actual object or stimulus. For example, at night time, a person may confuse or may say a rope to be a snake. So there is a true or an actual object or stimulus which is being misinterpreted as a snake. So this is illusion. Now, hallucinations, in fact, on the other hand, are false perception without an object or stimulus. For example, a person in delirium may say that he is seeing snakes on the floor. So there is actually no object or stimulus, but the person is still able to have a perception. So it's a false perception without an stimulus. Now, some of the important characteristics of hallucinations are, they are clear and vivid, they're as clear as a true object, as if it is truly present. Then they remain unaltered. That is, whatever person tries to do, they remain unaltered. Then another important point is they lie in the outer objective space. That is, they are lying outside of the person's body in a objective space. This point helps in distinguishing is what from pseudo hallucinations. Now, in pseudo hallucination, it is actually the object is in the inner subjective space. So, this is an important point to distinguish between hallucination and pseudo hallucination. The person may say in pseudo hallucination that the object is in the inner subjective space in the mind. Rest all points are similar to hallucination. Now, another important point in characteristic of hallucination is that it is independent of the will. That is, even if the person wills to bring or to remove the perception, it will not be able to do that. So, it is independent of the will. Now, let us discuss some of the important hallucinations. Now, most common hallucinations generally, especially in schizophrenia, are the auditory hallucinations. Auditory hallucination may be first person, second person, or third person. And third person hallucinations are characteristic of schizophrenia. Here it may be that running commentary is being given, or voices discussing the patient among themselves. So, these are characteristically seen in schizophrenia. Now, second are the visual hallucinations, which are generally seen in organic conditions. Then other are the olfactory hallucination and gustatory hallucinations, which are generally seen in temporal lobe epilepsy. Important. Then there may be tactile hallucination, may be seen in cocaine, as known as cocaine bugs. Now, some of the important or the other specific hallucination is the otoscopy, or also known as phantom mirror image. Now, here the person reports as if seeing an image of oneself in external space, and also knowing that it is oneself. That is, the person sees his image in the external space, and also he acknowledges it to be his own self. Now, opposite of this otoscopy is the negative otoscopy. Here the person looks into the mirror and actually sees no image. Hence it is known as negative otoscopy. So, the answer to, as we just discussed, answer to question 103 is B. autoscopic hallucinations. Now, let us discuss the next question. Awareness of having an illness is answer A, it is insight. So, answer to 104 is A, insight. Now, let us discuss briefly about insight. Now, insight is the conscious awareness and understanding of one's own psychodynamics and symptoms of maladaptive behavior. So, now insight is highly important in affecting changes in the behavior of the person. Until and unless there will be a conscious awareness and understanding of one's own psychodynamics and symptoms, only then we will be able to impart changes in the behavior. So insight is an important component of psychiatric illnesses. Now, there are various clinical rating of insights from 1 to 6. Let us discuss in briefly. First is the stage 1 is the complete denial of the illness, which may be typically seen in psychosis. Now, second is slight awareness of being sick, but then denying it at the same time. For once the patient may say that he is aware of being sick, but at the same time he may just deny that I don't have any illness. Then third is awareness of being sick, but here the person attributes it to external or physical factors. So there are certain factors in the let's say in the environment which the person is attributing to the illness. So this is 3, grade 3. Then in grade 4 again there is awareness of being sick. Now the person attributes it to unknown factors in the self. Grade 5 is the intellectual insight. Here, in intellectual insight, that is grade 5, there is awareness that the symptoms or the behavior are due to own particular irrational feelings or thoughts. That is, he has awareness that these behavior or symptoms are due to own irrational belief or thoughts or feelings, but does not apply the knowledge to present or future experiences. That is, the person is not applying the knowledge, although the person is aware, so that is what is known as intellectual insight. Then fifth, the highest level of insight is the true emotional insight. Here there is awareness which leads to significant changes in future behaviors. So this is the sixth grade of insight, that is true emotional insight. Now the next, which of the following is not a bizarre delusion? Followed by an alien from another universe, yes it is. Chip inserted in head to locate, it is. I am the immortal power, it is. Now my wife is definitely having an affair with a colleague, so the answer is C. So answer to 105 is C. Now let us discuss what are bizarre delusions. Now bizarre delusions are delusions which are scientifically impossible and culturally implausible. That is, they are ununderstandable. So important is they are scientifically impossible and culturally implausible. For example, as the examples in the question, that a chip is being inserted or aliens have captured me. Now non-bizarre delusions on the other hand, are false, but they can be true, can be possible. They are false, but they can be possible. It is not that they cannot be possible. For example, delusion of persecution. The person may say that the people are, someone is trying to harm him. So although it is false, but it is possible. Now, in DSM-4, the criteria of bizarre delusions was actually used as one of the criterias for schizophrenia, but subsequently it was removed in DSM-5. So this is about bizarre and non-bizarre delusions. Now let us discuss about the next question. Now here a 32-year-old male admitted with schizophrenia, and he claims that wife present with him is actually not the wife but a nurse who wanted to kill him. So which of the following is the diagnosis? So the answer is B, Capgras syndrome. Answer 106 is B, Capgras syndrome. Now let us discuss briefly about what are known as delusional misidentification. Now these are discrete but related syndromes, and the common point in this is the concept of doubles. So there are generally 4 delusions which are explained in the delusional misidentification. Now let us discuss each one by one. First is the Capgras syndrome, here the person believes that someone close to him or her has been replaced by an exact imposter. As an example in the question, that the person believed that the wife has been replaced by the nurse. So the imposter looks exactly the same as the person's close relative or friend. And this is most commonly seen in schizophrenia. Again, as in the question, the person was also suffering from schizophrenia. So now the second important syndrome is the Frigoli syndrome. Now, in Frigoli syndrome, the person believes that various people he or she meets are actually the same person in disguise. That is, there is no physical resemblance, the person but believes that this is actually the same person who is in disguise. Now, another way of remembering it is that the Frigoli syndrome, the word Frigoli syndrome is derived from the Italian actor's name known as Leopold Frigoli, who had ability to quickly change his appearance during the stage acts. So the same person changing his appearance multiple times. So this is Frigoli syndrome. Then comes the third syndrome, the syndrome of intermetamorphosis. Now, here there is a delusional belief that others may undergo changes in physical as well as psychological identity, culminating into a new person. That is, the person has a delusional belief that others may undergo changes which may be physical and psychological that can culminate them into a new person. So, now fourth is the syndrome of subjective doubles. Now, here there is a delusional belief of existence of physical duplicates, so much so that they also have a separate or a different psychological identity. That is, the person may believe that he or she has duplicates in the environment who have a different psychological identity. Now, another important point similar to this to be remembered is what is known as reduplicative paraamnesia. Now, here there is a delusional belief that identical places and events exists. So another important, maybe a MCQ. Now let us discuss the next question. Now question 107, the answer is countertransference means feeling therapist develops towards the patient during psychotherapy. So the answer to question 107 is A. Now let us discuss few important points of doctor-patient relationship. Now, first important point to remember here is transference. Now, transference is the conscious or unconscious emotional reaction of the patient towards the therapist, which is based on past relationship patient had with a significant other person. For example, during psychotherapy, a boy may develop transference towards the therapist, as that the therapist is just like my father who used to guide me. So such transference may develop. Now among doctors, it may be strongest with the psychiatrist, and sometimes in insight oriented psychotherapy, it may be, in fact, transference may be an important part of the treatment of the whole process, as these feelings may be hidden, but after transference that these feelings may surface and the person may be able to acknowledge such feelings. Now second is the countertransference. In countertransference, these are conscious or unconscious emotional reaction of the therapist towards the patient. Now it may be in the form of, say, disliking towards the patient, or it may be sexually attracted towards the patient. So this is countertransference. Now the term heteronormal means A, that the person is seen as normal by members of another society observing him or her. So the answer to question 108 is A. Now let us discuss briefly about the concept of normality. Now there are a lot of concepts of normality in psychiatry. One of them was given by George Mura. According to him, he described 4 conditions. First is the autonormal. Now autonormal is described as the person seen as normal by his or her own society. That is the society in which the person is living, they acknowledge him as a normal person. Then second is autopathological. Now, autopathological is when the person seen as abnormal by his or her own society. Then, third is heteronormal. Now, here the person seen as normal by members of another society who are observing him. That is, somebody from outside society is observing a person in the society, and according to them he is normal. Similarly, heteropathological. Here the person is seen as abnormal by members of another society who are observing him from the outside. So, according to them, he is heteropathological. So, these are the 4 important terminologies given by George Mora. Let us go to the next question. Now, 56-year-old man is brought to you by wife as she noted a personality change in the person. The patient is being interviewed. He answers every question with the same 3 words. So, the person's behavior is best described by answer D, that is perseveration. So, answer to question 109 is D, perseveration. Now, as we may remember, we just discussed perseveration as a disorder we discussed under disorder of thought, under disorder of flow or stream as a disorder of continuity. So, we just discussed under disorder of continuity. Now, what is perseveration? Now, in perseveration, the mental operations, they tend to persist beyond the point of relevance. For example, that is, at some point they were relevant, but they continue to persist after some point and they become irrelevant or loses the relevance. For example, let us see with an example. A person is asked, what is your name? And person gives a correct answer. Now, again, the person is asked, what do you do? Or then where do you live? Are you married? Now, the person replies with the same answer as the answer he gave when he was asked, what is your name? But they are now not relevant. So, this is perseveration. Now, perseveration is an important sign of organic brain disease, and it may be nearly pathognomic sign. That is, presence of perseveration, you should always look for organic causes. They are nearly pathognomic, but it may be also seen in schizophrenia. Now, to also name certain. There are in fact 3 types of perseveration. This may be a future MCQ, so you should at least know the names of the various types of perseveration. You may be asked which of the following is not a type of perseveration. So these are compulsive repetitions, then impairment of switching, then ideational perseveration. So important to remember just the names, that if you may ask, there may be another option and you may to ask to tell which of the following is not the types of perseveration. Then let us go to the next question. Now, what is asynesthesia? Now, answer is A. Answer to 110 is option A. Now, asynesthesia is the loss of sensation of physical existence. Sensation of physical existence. Now, let us discuss few more terms. Alexithymia, it is described as inability or difficulty in describing or being aware of one's own feelings or emotions. So that is alexithymia. It may be asked again as an MCQ. Acalculia, we all know that it is the loss of ability to do calculations. Now, answer to 111. Now, this is an important question. Which of the lobes of the brain can manifest as psychiatric illness? The correct answer to this question is answer 111 is option A. That is the frontal lobe. Now, let us discuss few important things about the frontal lobe. Now, as we all know, this is the largest lobe of the brain. Then also it mediates behavior, and frontal lobe disorders may be disorders of cognition, mood, or impulse control. So, these may be the manifestations of frontal lobe disorders. Now, in the frontal lobe, there is a prefrontal lobe. Now, the left prefrontal lobe may be attributed to depressive symptoms or uncontrollable lying. The uncontrollable crying, and right prefrontal lobe may be associated with laughter or euphoria. So it may be remembered as the left lowers the mood, so there is a depression, and right may rise mood, so there may be laughter or euphoria. Okay. Now there are also important prefrontal lobe syndromes associated or explained. We'll just discuss in briefly about them. So prefrontal syndromes, there are 3 prefrontal syndromes. First is the orbitofrontal syndrome, then second is the dorsolateral prefrontal syndrome, then third is the mediofrontal or the medial frontal syndrome. Now let us discuss key important features of each of them. Now orbitofrontal syndrome is associated with disinhibition, poor social judgment, then it may be euphoria, inappropriate jocularity, then there may be a utilization behavior. In utilization behavior, the person picks up whatever thing is around him and tries to use them or utilize them. This is utilization behavior. Then there may be imitation behavior may also be seen. So characteristically and disinhibitory kind of a behavior is seen in orbitofrontal syndrome. Now in dorsolateral prefrontal syndrome, it is generally seen as a deficit in the executive functioning, that is the person is not able to carry out complex tasks. There is poor abstraction may be seen in this. Now in medial frontal syndrome, there is apathy, which is the marker behavior of medial frontal syndrome. There may be reduced interest and there may be poor motivation seen. So generally after, let us say, head injury, there may be one of the following lobes of the prefrontal area may be involved and such behavior may be seen. So all these are important future MCQs. So you should be aware of at least the key behaviors of each of these syndromes. Now let us discuss the next question. Chronic hepatitis C infection is associated with psychological illness that may worsen with interferon alpha. So the answer of 112 is D. Now chronic hepatitis may lead to various psychological or psychiatric illnesses, and one of the common ones is the depression. Now if drug like interferon is used, which may exaggerate the depression. So let us discuss briefly about the list of various drugs which may be associated with depression. Now let us discuss class by class various categories of drugs. So let us discuss first the anti-hypertensive drugs which may cause depression. Important to remember is propranolol, then methyl dopa, then clonidine. Second class of drugs include antiparkinsonians, some drugs which may include levodopa, then bromocriptine, then amantadine. Then third class of drug includes anticonvulsants, which may be include phenytoin, barbiturates. Then next may be sedative hypnotics group of drug, which may include drugs like benzodiazepines. Then fifth includes neuroleptics, antipsychotic drugs. Important ones include butyrophenones and phenothiazines. Then next class of drugs include the antibiotics, including penicillins, neuroepileptics, neuroleptics in the form of butyrophenone, then phenothiazines, then sixth are the antimicrobials or antibiotics in the form of penicillins, then tetracycline, then metronidazole, then acyclovir. Now, another important class of drugs associated with depressive symptoms include anti-neoplastic drugs. So, the important drugs are azathioprine, then vincristine, bleomycin, then interferons. Endocrinal agents, the agents important, very important in this are corticosteroids, oral contraceptive pills, androgens, miscellaneous NSAIDs, non-steroidal anti-inflammatory drugs, then disulfiram, salbutamol, lidocaine, cardiac glycosides. So these are some of the important list of drugs which may present as psychiatric illnesses. So some of them are very important to remember, including the antibiotic group, the anti-neoplastic groups. Important corticosteroids are another important, and the miscellaneous category, including disulfiram, salbutamol. These are all important drugs which may be associated with depressive symptoms. Now, answer to question 113. A man presents with euphoria, laugh uncontrollable. So the correct answer to this is, as we had previously discussed, the prefrontal cortex, the right rises. So it is the answer is B, that is right prefrontal cortex. So now let us discuss about the question 115. All are true about dementia except. So the answer to 114 is option C, that is delirium is present, that is it is not present in dementia. Now let us discuss briefly about the concept of dementia and delirium. Let us discuss simultaneously. So answer to 114, answer is C. Now let us discuss first what is dementia. Now in DSM-5, this is now described under major neurocognitive disorder. So a new term of dementia in the DSM-5. Now this is characterized by dementia is characterized by significant decline, significant in fact cognitive decline in various domains. The domains include language, learning and memory, complex attention, then perceptual motor, social cognition, and executive function. So these are the important domains which may be affected in dementia. Now there is a progressive cognitive decline or impairment which is in clear consciousness, that is the consciousness is not impaired. This is very important, which helps us distinguish it from delirium. Now we will discuss briefly then delirium. Now in delirium there is impairment of consciousness. It may be from clouding of consciousness to even coma. Then there is global disturbance of cognition. There may be disorientation seen, and also there may be disorientation, and also there may be hallucination seen. Most common is the visual hallucination. Then third important is the psychomotor disturbances may also be seen in delirium. Psychomotor disturbances may also be seen in delirium. There may be hyper or hypoactivity may be seen. Both may be seen. So then there may be disturbance of sleep-wake cycle, and it is said in delirium generally there is a reversal of sleep-wake cycle, that is the person may be awake in the night and may be sleeping during the daytime. It is again an important characteristic of delirium. Then there may be emotional disturbances. Emotional disturbances may be seen in the form of depression or anxiety or fear. These may be seen. So these are the things which are seen in delirium. While in dementia, as we discussed, there is cognitive decline in various domains we just discussed. It is not only memory but all the other various domains which are disturbed, but it occurs in a clear consciousness, while for delirium there is necessity of impairment of consciousness. There may be initially clouding of consciousness, but subsequently the person may even land into coma. So these are the important factors which help us distinguish. Now we may also discuss some important points of delirium and dementia, which may also have a better understanding of the two conditions. Now let us see, if we see on the onset, delirium is generally a rapid onset condition, while dementia is a slow onset condition. Then if we see duration, it is generally from hours to weeks, and dementia may be from months to even years. So then in delirium, attention generally fluctuates, while in dementia it is generally preserved. Now memory, generally the recent or the immediate is impaired, while here the generally remote may be impaired. Now speech, it may be incoherent. There may be, and here there may be word finding difficulty, may be seen in dementia. Then here the sleep wake cycle, as we just discussed, there is frequent disruptions and there may be reversal, while here there is fragmented sleep seen in dementia. Now awareness, here awareness is generally decreased and here it is unchanged. Also alertness, here maybe person may be hyper vigilant or hypovigilant, and it is usually normal. So these were some of the important factors which help us distinguish between delirium and dementia. Now answer to 115, which of the following is true about delirium? Yes, there is clouding, disorientation, visual perception, as we discussed. So answer to 115 is option D, that is all are true. Now 116, which of the following is the highest risk for developing delirium? Here now another important point to remember is the risk factors increases with the degree of the severity of the illness, medical illness. So it is highly seen in elderly population, also in person admitted to the ICU settings. They're all critical patients, so there is risk of delirium increases. Also important point to remember here are that the major neurotransmitter associated with delirium is acetylcholine, and the major neuroanatomical region or the area affected in delirium is the reticular formation. Important MCQs. So as we discussed, so the answer to this question would be, answer to 116 would be an elderly woman who is admitted to ICU with again a critical condition of esophageal rupture. So amongst the four, this seems to be most at the highest risk for developing delirium because of the condition. Now, answer to 117, mutism and kinesis in a person who is awake and alert, which is best described, it is described as answer C, that is stupor. So, the answer to the question is 117. Is C, stupor. Now, let us discuss in briefly now mutism and akinesia, that is inability to initiate speech, and akinesia is action. There is inability to the person to initiate speech or action in otherwise patient who appears awake and alert. So this is stupor. Now, it is also known as akinetic mutism, and it is generally seen with the lesions of diencephalon and upper brain stem, and may be seen with lesions of frontal lobe and basal ganglia. In these lesions, akinetic mutism or stupor may be seen. Now, a similar condition described as locked-in syndrome, which is having a near similar presentation. It is due to involvement of motor pathways in the ventral pons, the locked-in syndrome. So it is a similar condition to stupor or akinetic mutism. Now, answer to 118, amnesia typically occurs in, the answer is A, that is head injury. Now, let us discuss important points about amnestic syndrome or amnesia. So, answer to 118 is A, head injury. Now, let us discuss about amnestic disorder. Now, it may be of two types. One is the organic amnestic syndrome, and the other is amnestic syndrome, which is generally induced by psychoactive substance like alcohol. Now, few important characteristics of organic amnestic syndrome includes, there is memory impairment, which is characterized by both impairment in the recent memory, so there will be difficulty in learning new material or new things, so there should be impairment in the recent memory, as well as inability to recall past events. So there will be impairment in both, and there should be absence of defect in immediate memory, that is immediate memory should be intact, which can be tested by digit span. Then there should be also absence of clouding of consciousness and disturbance of attention, which are generally seen in delirium. Then third is there should be absence of global intellectual decline, which is seen in dementia. That is, these things should not be present. Neither there should be defect in immediate memory, neither clouding of consciousness, nor there should be global impairment of intellectual decline, that is seen in dementia. So these things should be absent. And also there should be objective evidence from examination or investigation and history of insult to the brain, and these may be assumed to be responsible for the clinical features. So then we label it as organic amnestic syndrome. Now some of the important causes of amnestic disorders, as we just discussed, it can be primary to the brain, and these may be systemic causes. So the primary causes include seizure disorder, TBI, that is traumatic brain injury or head injury, as in the option. Then there may be tumors, cerebral, especially cerebral tumors. Then there may be stroke, especially the posterior cerebral artery region. Then there may be paraneoplastic syndromes. Then infections may be causes, especially herpes simplex virus, HSV. Then metabolic causes like hypoxia or the hypoxic injury. Then ECT, electroconvulsive therapy, again may a cause, especially retrograde amnesia. And the systemic causes, they may be alcohol induced, known as Korsakoff's. Then it may be because of thiamine deficiency, hypoglycemia, and they may be substance induced. Other than alcohol, it may be sedative hypnotics. So these are systemic causes. So as in the option, the answer is traumatic brain injury or head injury. This was about amnestic disorders. Now let us go to the next question. Now answer to 119 is A, that is unconscious conflict. Psychodynamic theory of illness is based on the unconscious conflicts. Now let us discuss in briefly about it. So answer to 119 is A, unconscious conflicts. Now the psychodynamic theory is based on psychoanalysis, which was term given by Sigmund Freud, also known as the father of psychoanalysis. Important. Now, psychoanalysis, in this the theory, it is a theory which states that unconscious conflicts and childhood experiences, memories play an important role in human behaviors, emotions, and psychiatric disorders. So, the unconscious conflicts as well as the childhood memories and experiences are important for the development of psychiatric disorders. Now, the conflict which they are stating, the conflict, it may be between instinctual drives and external reality, or it may be between internal agencies like the id, ego and the superego. So, it may be in the conflicts may be between them, which is actually the structural theory. These three are explained in the structural theory of mind given by Freud. So, the answer is unconscious conflicts. Now, let us go to the next question, 120. True about late onset schizophrenia is that the answer is option A, that is onset after 45 years of age. So, let us discuss few important points. The answer is A. Now, let us discuss some few important points about the good and the bad prognostic factors in schizophrenia. And let us discuss now. First is the acute or the abrupt onset is a good prognostic factor, while insidious onset is a bad prognostic factor. Then late onset, which is described as onset after 45 years, is a good prognostic factor, while early onset is a bad prognostic factor. Then third important point is the important subtypes which are associated with good prognosis is catatonic schizophrenia, paranoid schizophrenia, and the subtypes which are associated with poor prognostic factors include simple schizophrenia, disorganized schizophrenia, and undifferentiated schizophrenia. These are associated with poor prognostic factor. Then female is a good prognostic factor in females, and males generally have a poor prognostic factors. Then prominence of positive symptoms again is a good prognostic factors, while prominence of negative symptoms in schizophrenia is a poor prognostic factor. Then presence of affective or the mood symptoms is a good prognostic factors, while absence of affective symptoms is a bad prognostic factor. Then seventh is the family history of mood disorder, that is a person with a family history of any mood disorder is a good prognostic factor, and family history of schizophrenia is a bad prognostic factor. So these are some of the very important good and bad prognostic factors in schizophrenia, and late onset is one of the good prognostic factors in schizophrenia. Now let us discuss the next question. A patient of schizophrenia treated for 5 years developed perioral movement. So the person is on since 5 years on antipsychotics most probably. The likely diagnosis is, the answer is option A, tardive dyskinesia. Now let us discuss in briefly various movement disorders which are induced by neuroleptics or the antipsychotics. So let us discuss the neuroleptic induced movement disorders. So these are some of the very important for the examination point of view, and you may be given a you may be asked the diagnosis. So the first neuroleptic induced movement disorder which we will be describing is the neuroleptic induced Parkinsonism. Now these usually develop within days to weeks after start of antipsychotics or after increasing the dose. Now they may be characterized by rigidity, which may be lead pipe or cogwheel. Then there may be tremors may be seen, generally resting tremors may be seen with 3 to 6 Hz frequency, and there may be bradykinesia. They all may be present together or one or two at the same time. Generally, the risk factors associated are the women, that is in women, as well as with age more than 60 years or high doses of antipsychotics. Now, second important movement disorder is the acute dystonia. Now, it may develop within days if injectables are used, or in fact not in days, but in fact within minutes of use of if injections are used, or within days of oral medications. Now they may be characterized by important characteristics or important points are, they may be characterized by abnormal posturing of head and neck, like torticollis may be seen. Then there may be spasm of jaw muscle, there may be, that is trismus may be seen. There may be difficulty in speaking or swallowing. There may be laryngospasm may be there. There may be deviation of the eyes may be seen. There may be, that is oculogyric crisis may be seen. Then there may be tongue protrusion may be seen. Then there may be abnormal position of the limbs or the trunk may be seen, that is opisthotonus in fact may be position may be seen. So they generally, if in using the injectable, they generally within minutes or within days, and these are very distressing to the patient. They're very distressing to the patient. And important risk factors for acute dystonia is young male, then recent use of cocaine, and liquid or parenteral use of the drug. So now let us discuss the third acute akathisia. Now akathisia means never to sit down. Now in akathisia generally it develops within 4 weeks of increasing or starting the drug, and there is the clinically there is complaint of inner restlessness. There is complaint of inner plus there is objective evidence of outer restlessness, which may be in the form of fidgeting or swinging of legs. Then there may be rocking from foot to foot while standing. Then there may be pacing around, there may be pacing or there may be lifting the feet as if the person is marching. Then there may be crossing and uncrossing of legs when sitting. There may be also inability to sit or stand for several minutes. So there is in any one of the following, one of these may be present as an objective evidence of restlessness, and there is also the person complaining there is inner restlessness. So we describe it as acute akathisia. That is when it develops within 4 weeks. Then there may be chronic akathisia. That is when persistent, if it persists for more than 3 months, it is chronic. And there may be in fact tardive akathisia, which is generally delayed onset. Now various important risk factors for akathisia include old patient, females. Then iron deficiency again is a risk factor. Then cognitive dysfunction is a risk factor. Then mood disorder is a risk factor. Then predominance of negative symptoms is a risk factor. So you may be asked, the person is not able to sit, reporting of restlessness, what is the diagnosis? So it is akathisia. Then fourth important neuroleptic induced movement disorder we'll discuss is tardive dyskinesia, as asked in the question. Now the word tardive means to appear late, that is after subsequent use of the drug it is appearing, not immediately or within few days it is appearing. So what are the clinical features which are seen in tardive dyskinesia? There may be involuntary movements of the tongue, as in twisting or protrusion may be seen. So there may be involuntary movement of the tongue. Then there may be involuntary movement of the jaw, like chewing movement. Then there may be movements of the lips, like smacking movement or puckering movements. And there may be some movements of the trunk and extremities. So this is tardive dyskinesia. Now it generally develops after at least 2 months of exposure to dopamine agonistic antagonist, the dopamine antagonist, and generally 1 month we say if the age is more than 60 years, and they generally develop, that is the exposure should be for at least 2 months. Now they generally develop while on treatment or within 4 weeks of stopping oral drugs or 8 weeks after stopping long acting injectables, and they should be for at least 4 weeks. This is how we describe tardive dyskinesia. Now in tardive dyskinesia, the important risk factors include increased age, then pre-existing Parkinson disease, then any brain damage, and also especially the first generation antipsychotics. So these are some of the important risk factors. Now let us discuss the last and very important, in fact several times asked as a MCQ, as a clinical condition, is the neuroleptic malignant syndrome. Very important. So you may be given a clinical condition, you may be asked to describe the syndrome. So now there is a Levinson criteria which is given to describe neuroleptic malignant syndrome. Now it has 3 major criterias and 6 minor criterias. The major criteria include fever, rigidity, and increased creatine phosphokinase (CPK) levels, which are generally more than 1000 to 1 lakh, up to 1 lakh international units. Now important minor criteria include, there is tachycardia, tachypnea, then abnormal arterial pressure, then fourth is the altered sensorium, then diaphoresis, and sixth is leukocytosis. To diagnose using Levinson's criteria neuroleptic malignant syndrome, generally 3 major criteria should be present, so we diagnose it, or 2 major plus 4 minor criteria must be present for diagnosing neuroleptic malignant syndrome. Now in neuroleptic malignant syndrome, 2-3 important things to remember is that rhabdomyolysis leads to myoglobinuria, which may lead to acute renal failure, and also they are generally seen as low serum iron levels. So this was about neuroleptic malignant syndrome. Now let us discuss another important question, drug of choice of resistant schizophrenia. Here the answer is option B. So answer to 122 is option B, clozapine. Now let us discuss few things about clozapine. Now clozapine is a second generation antipsychotics, also known as atypical antipsychotic drugs. Now it has a T half of around 12 hours. Now in 1970s, this drug was withdrawn from the market. This drug was withdrawn from the market because of development of cases of agranulocytosis, which led to death in few cases. But again it was in 1990 it was reintroduced as a drug for treatment resistant schizophrenia or TRS patients. Now it is relatively, if we see the receptors on which it acts, it relatively has low affinity. It has low affinity with the D2 receptors, hence it has less EPS potential, important, but also it has blockade, it also blocks 5-HT3 alpha 1 alpha 2. These are also the receptors which it affects. Now important to remember, especially in clozapine, are the important black box warnings. Now first is that it may lead to agranulocytosis. Risk is generally 0.73% in the first year and 0.73% in the first year and 0.07 in the second year. That risk decreases in the second year. The first risk it has higher risk. Now generally before start WBC count should be greater than or equal to 2500 cells per millimeter cube, and the absolute neutrophil count should be more than equal to 2000 cells per millimeter cube. Only then we start, and regular repeated monitoring of WBC and ALC also advised. Now other important black box signs are myocarditis, which develops in around 2.8 per lakh population. So there may be a clinical question, a person on clozapine has developed sore throat, has developed fever. What is the likely diagnosis? It could be because of agranulocytosis. Again with this, if the person is having tachycardia, is complaining of chest pain, you need to urgently do a ECG. You need to rule out myocarditis. So these may be asked as a clinical conditions. Third important black box is the seizure. Seizure risk is around 5 to 10%, and it generally increases, the risk increases if it is used at doses more than 600 milligram per day. Then it also increases mortality in elderly with dementia. And fifth important black box warning is the severe cardiovascular and respiratory events, although these are generally rare. So these are the few important black box warning, and all of these should be remembered, and these may be asked as clinical questions for clozapine. Now let us discuss the next question. True about type question 123. The true about schizophrenia type 1 is that answer is D, that it responds well to treatment. Now 123, option D. Now let us discuss about the two syndromes. In literature, initially schizophrenia was described as type 1 and type 2. This classification was given by T.J. Crow as described two syndromes. Now they may be type 1 and type 2. a few important points to remember in this is that type 1 generally is the positive symptoms, while type 2 generally are the negative symptoms. Then they are generally treatment responsive and they are generally less responsive. Then they generally have normal ventricle size, they generally have enlarged ventricle size. Then in type 1 they generally has better prognosis and they generally have poor prognosis. Now also they generally have functioning well. They generally functioning well before the onset of symptoms, while type 2 they have poor history of social and educational functioning before the onset. So these are some of the important points to distinguish type 1 and type 2. They are treatment responsive. Now let us discuss the next question. Now the question is, following are positive symptoms of schizophrenia except the correct answer is option D, anhedonia. This is not a positive symptom, in fact it's a negative symptom. Now let us discuss in briefly, that is question 125. In fact this is question 125. Okay, we will discuss, before that we will discuss question 124. Which of the following drug is less likely to cause weight gain? Here the answer is molindol. Now let us discuss question 124. So the answer is D, molindol. Now drugs, now antipsychotics, especially the second generation antipsychotics or the atypical antipsychotics, they are known to cause metabolic syndrome. They are known to cause metabolic syndrome, that is they may cause obesity, hyperglycemia, dyslipidemia, and hypertension. These are generally more for the second generation antipsychotics. Now let us discuss the mechanism of weight gain because of these drugs. The mechanism is generally the 5-HT 2C antagonism, then H1 antagonism, and increased serum leptin levels. These are the proposed mechanisms. These are the proposed mechanism by which the antipsychotic, especially the second generation antipsychotics, cause weight gain. Now let us discuss some of the drugs. Now the drugs, high risk drugs category includes clozapine and olanzapine. If both are in the options, then go for clozapine. Then moderate risk class of drugs include chlorpromazine, quetiapine, risperidone with low risk generally includes amisulpride, aripiprazole, then haloperidol, then trifluperazine, then ziprasidone, then perfenazine, they have a low risk. Now molindone is the drug which may be considered at weight neutral or may even decrease. So this is the correct answer. In the list, if asked, you may as well refer to the list and see if any of the options are given, then you may see if it is high risk, then you can give the answer as those. If one of the moderate risk is present and rest all are the low risk, then the moderate risk would be the drug which causes weight gain. So this is important to remember. Now we'll discuss question 125, that is, for which of the following are positive features of schizophrenia, except as we had discussed, the answer is P, that is anhedonia. Answer to 125 is B, anhedonia. Now, as we just described, earlier it was seen as the schizophrenia was described in the domains of type 1 or type 2 or presence of positive or negative symptom. But now currently the symptom domains in schizophrenia there are basically 5 symptom domains. So their first is the positive symptoms, then second is the negative symptoms, third are the affective symptoms, then fourth are the cognitive symptoms, and fifth are the aggressive or the disorganized symptoms. Now let us discuss one by one few of the important things. Now positive symptoms, as we know, the positive symptoms are first or the most common in schizophrenia. Now hallucination, and most common hallucinations are the auditory hallucination, nearly 70% of the cases. Then second most common is the visual hallucinations. Other hallucinations may be tactile or olfactory or gustatory hallucinations. Then second is the delusions. Now delusion most common, as we know, is the delusion of persecution. Now coming to the negative symptoms, they are basically described 5 negative symptoms seen in schizophrenia. These include, first is anhedonia, which is the most common, then avolition, then third is affect blunting, fourth is apathetic social withdrawal, and fifth is alogia. Now these negative symptoms may be primary negative symptoms or secondary negative symptoms. Now primary negative symptoms, they appear to be intrinsic to the disease process, and secondary negative symptoms may be because of There may be because of long-term institutionalization. Long-term institutionalization. They may be secondary to antipsychotics, as we just discussed, that it may lead to extrapyramidal symptoms or neuroleptic induced movement disorders, which may appear to be negative symptoms. Then it may be due to, third, it may be due to other symptoms. For example, person who is very fearful that people are around him, there is delusion of persecution, so he may show negative symptoms like anhedonia, social withdrawal. So it may be due to other positive symptoms, and it may be due to other symptoms like depression. So you need to rule out these causes to label it as primary negative symptoms. So also the other three domains, like there is also affective symptoms may also be seen in schizophrenia. Cognitive decline is also very well established nowadays for schizophrenia, and also aggressive or disorganized symptoms or behaviors. So these are the 5 symptom domains which are now these days being postulated for the for symptoms in schizophrenia. Now we will discuss the next question. Now, answer to question 126 is A. Dopamine hypothesis is for schizophrenia. Now, in schizophrenia, there was a proposed dopamine hypothesis. Which says, it's a traditional view which said that there is too much of dopamine which is leading to schizophrenia in the brain. Now, this was based on the 2 observations. How it was proposed? It was based on 2 observations. First was that there was efficacy and potency of antipsychotic drugs. That is, it was seen that drugs which are blocking D2 receptors, blocking dopamine receptors, is actually efficacious in schizophrenia. So it was postulated that it may be that because there is increasing dopamine. Second was the drugs that increase dopamine, for example cocaine, amphetamines, they are psychomimetic. So this led to the dopamine hypothesis. But now we know that that is not only the dopamine is increased, in some pathways dopamine is even decreased. So we'll discuss battery. Low battery low. So we'll be discussing how that not only it is increased, but in some pathways it is even decreased. So basically there are 4 important major dopaminergic pathways in the brain. Let us discuss. Dopaminergic pathways. Now, first is the mesolimbic pathway. Now, this pathway, it is from the ventral tegmental area of the brainstem from where there are dopaminergic cell bodies are there, and to the limbic system, especially the nucleus accumbens in the ventral striatum. Here it is seen that usually it is seen that dopamine is increased, dopamine is high, and this circuitry, this pathway is responsible for positive symptoms. So generally this traditional view which was explained, it especially holds true for the mesolimbic pathway. Now the second important pathway is the mesocortical pathway. Here it is from the ventral tegmental area in the brainstem to the prefrontal cortex. Here generally there is decrease in the dopamine, that is there is hypoactivity, and this area is responsible for this decrease in the dopamine in the circuitry is responsible for the negative symptoms. Now third important pathway is the nigrostriatal pathway. Now this is from the nigrostriatum. This is from the substantia nigra. From the substantia nigra in the brainstem to the basal ganglia or the striatum. So, and blockage, this is important, significant is that the D2 blockade in this region because of antipsychotics lead to extrapyramidal symptoms or the movement disorders we just described. So this pathway is important in the EPS. Now the fourth major pathway involved is the tuberoinfundibular pathway of the dopaminergic neurons. Now this pathway is from the hypothalamus to the anterior pituitary. Now we all know that normally dopamine normally inhibits prolactin, but when because of the antipsychotics the dopamine is inhibited, the antipsychotics inhibit dopamine, this in subsequently leads to increase in the prolactin levels, which is responsible for various side effects including galactorrhea, then there may be amenorrhea in females, and also other sexual dysfunctions in both males and females. So again the latter two pathways are basically are responsible for the side effects. So these are the four important pathways. Now answer to question 127, catatonia, all are characterized except the answer is B, grandiosity. So answer to question 127 is B. Grandiosity is not seen in catatonia. Now let us discuss about catatonia. Now the term catatonia was given by Carl Ludwig Carlborn in 1874. Important to remember that it was described by Carl Ludwig Carlborn. Now let us discuss the various important clinical features, clinical findings which are seen in catatonia. Now first is stupor may be seen, then mutism, then agitation may be seen, then there may be posturing may be seen, which is spontaneous and active maintenance of posture against gravity. Now, then there may be negativism may be seen. That is, if a person is told to do something, the person may just do the opposite of it. And if in extreme, this is generally known as Gegenhalten. This may be seen. Then there may be catalepsy, not cataplexy, which is seen in narcolepsy. It is catalepsy is seen, which is described as passive induction of postures held against gravity. In posturing, it is a spontaneous and active maintenance, while in catalepsy, if someone makes the person posture somehow, that is passively, that is maintained against gravity. So this is catalepsy. Then other feature include waxy flexibility, that is, the person becomes very flexible like a wax. That is, the person may be molded like a wax. Then next is automatic obedience. Automatic obedience may be Mitmachen, which is the person, if despite being told to resist, the person allows the examiner to position the body. So it is, he is abiding by whatever the person is doing, although if he is even told to not do that. Then in extreme cases, it is called Mitgehen. For example, even just by touching the person, touching by your finger towards the back, the person may just fall down. So it is completely abiding by what the person is being done. So this is Mitgehen. So it is Mitmachen and Mitgehen. These are the important things. Then there is mannerisms. Mannerisms may be seen, which is odd, purposeful movements. The repetitive, odd, purposeful movements may be done. For example, the person may just salute. So it's a purposeful movement, but it is odd and it is repetitive. Then there may be Stereotypy may be seen. Stereotypies, these are odd but non-purposeful. That is, for example, just moving hand. These movements do not have any purpose, but the person is doing odd. These are odd and they are repetitively done. Then another important one is grimacing, like lips exaggeratedly puckered, exaggeration and puckering of lips. Then important is echolalia. Here the person repeats whatever the other person is saying. Then there is echopraxia. That is, the person repeat the actions of the other person or the examiner. So this was about catatonia. Now in question 128, as we can see just described, this seems to be following a posture. There is a maintenance of posture which is held against gravity and seems to be a spontaneous posture. So the answer, the description is described as option C, that is catatonia. Now 129, there is the image shown. So the best answer to this question is answer 3, C, that is thyroidazine. Let us discuss thyroidazine. So answer to 129 is option C, thyroidazine. Now thyroidazine is a first generation antipsychotic, and various side effects associated with it. Now before that, let us discuss that it is a low potency D2 blocker. So it has one of the least EPS potential causing drugs. Now it has a T half of around 9 to 30 hours. Now its various side effects includes sedation, anticholinergic side effects, hypotension, now it also causes, as shown in the picture, it also causes pigmentary retinopathy with choriocapillary atrophy, which is described in the figure, and it is generally irreversible with doses greater than 1000 milligram per day. So it is generally said that it should not be prescribed at doses more than 800 milligram per day. Then it also causes QTC prolongation. That is why it is not used, generally not used nowadays. And fourth, it also has various sexual side effects. Sexual side effects are also commonly seen with it, like priapism, then decreased libido, then retrograde ejaculation. So these are some of the important sexual side effects. So this was about thyroidazine. Now let us discuss the next question. Neurotic depression is usually associated with anxiety. The correct answer is option A. So answer to question 130 is A. Now depression, as in traditional view, it may be described as neurotic depression and psychotic depression, which is also known as endogenous depression or melancholy. Now, neurotic depression in ICD, used term in ICD-9 when replaced by dysthymia in ICD-10, and in DSM-5 it is known as persistent mood disorder in DSM-5. Now it is basically subsyndromal depressive symptoms are present, along with some anxiety symptoms may be present, and the symptoms generally occur for around 2 years. So this was about neurotic depression. Now coming to the next question, all are features of atypical depression except. So the correct answer is D. Better response to TCAs, tricyclic antidepressants than SSRIs. No, in fact they show good response to MAO inhibitors as well as SSRIs than the TCAs. So let us discuss. This is also a recently asked question, so we should discuss about it. Atypical depression. Now first important point is that there is mood reactivity is there. That is, the person's mood brightens in response to actual or a potential positive event. So there is mood reactivity is there, which is generally not seen in depression, that even if the person is brought to a positive or a potentially positive life event, the person's mood may remain depressed. But in atypical depression, the mood here brightens. And in criteria B, 2 or more of the following should be present, which include: first is significant weight gain or increased appetite. Then there is hypersomnia, that is increase in the sleep. Now these are generally described as reversed vegetative symptoms. Now generally in depression we have weight gain or decreased appetite and decreased sleep, but it is the opposite. It is the reversal of the vegetative symptoms seen in normally depression. Then there is laden paralysis. That is, the person reports of heavy laden feeling of arms and legs, that is as if they are laden with heavy things, so it is difficult to carry moving with them. So this is laden paralysis is reported. Then fourth is there is long standing pattern of interpersonal rejection sensitivity there is interpersonal rejection sensitivity which is seen. That is interpersonal, there is the, if the person is rejected or any minor issues there, he is very sensitive to these rejection issues, and so much so that they result in these result in impairment in functioning, social, occupational functioning, these are also impaired. Now, these were the important clinical features of atypical depression. Now, atypical depression, and the few important points regarding them is that they are younger age of onset. If they occur at there is more severe psychomotor slowing is there. Then they also have a long-term course. They also have more coexisting disorders like panic disorders, substance use disorders, somatization. If these are seen, generally diagnosis of BPAD, bipolar affective disorder, one is seen in long run, and they also sometimes have seasonal pattern. Now, treatment, if we discuss, there is a strong evidence of monoamine oxidase inhibitors, but since these are generally not used nowadays, so other drugs like SSRIs, bupropion also are useful. In fact, TCAs have very less role in treatment of atypical depression. So, this was about atypical depression. Now, drug of choice for rapid cycling is in. So, the answer is option C, that is sodium valproate. So, the answer is C of question 132. Now, let us discuss what is rapid cycling. Now, rapid cycling is when there are 4 or more episodes. These may be of depression, mania or hypomania per year. So, 4 or more episodes are occurring in a year. This is called as rapid cycling. Then what is ultra rapid cycling then? It is when 4 or more episodes are occurring in a month. So, this is ultra rapid cycling. Also, there is a term in literature known as ultra rapid cycling or ultradian. This is when 4 or more such fluctuations or episodes are occurring in a day. So, now generally you should be at least aware of what is rapid cycling. Now, what are the various factors which are associated with rapid cycling? Now, more in female, so female gender, then person with borderline hypothyroidism, then in menopause, then long-term aggressive use of antidepressants, so these are also, it is more common in BPD 2 than 1. rapid cycling is more common in BPAD 2 than 1. Now, treatment includes valproate is the treatment in rapid cycling. Now let us discuss the next question. A major depression is defined as a depressive mood on daily basis for a minimum of duration of. So the correct answer is of 133 is option A, that is 2 weeks. Option A, that is 2 weeks. Now let us discuss some of the important criterias, duration criteria in fact, which may be asked as MCQs. Now before that, moving to that, we just briefly discuss that there are generally two criterias or the two guidelines which we generally see. First is the ICD-10 and the other is the DSM-5. Now ICD-10 or the International Classification of Diseases 10th revision, now even we are expecting a revised version ICD-11, although advanced preview is out, but the final version will be available by 2021 ICD-11. So this is given by World Health Organization, while DSM-5, that is Diagnostic and Statistical Manual, this is for the classification of psychiatric illnesses, is given by the APA, that is the American Psychiatric Association. So these are the two generally well followed guidelines for the criterias. Now let us see, for these basically for mood disorder they generally have a consensus, both are giving similar criteria. For example, for depressive episode, the symptoms should be present for more than 2 weeks. For an episode of hypomania, the symptoms should be present for more than 4 days, 4 or more days. Then for mania, this may be more than equal to 7 days or 1 week. So, or if the person prior to that, even if the person requires hospitalization, then also you can diagnose it with mania. So this is the time duration criteria for the mood disorder. Now for psychosis, they vary. Now ICD-10 describes acute and transient psychotic disorder which is generally of less than 1 month criteria, and if it persists, especially if predominantly delusions persist, so then it leads to diagnosis of persistent delusional disorder if it is more than 3 months. Now symptoms describe schizophrenia if the symptoms they persist for more than 1 month. While this was about ICD-10, while DSM-5 describes brief psychotic disorder, symptom less than 1 month, then schizophreniform disorder if symptoms are more than 1 month but less than 6 months, and schizophrenia if the symptoms are more than 6 months. So this is how both describe the schizophrenia. Now let us go to the next question. A male started alcohol at 20. Question 134. adolescent boy is suspecting to be suffering from alcohol, so it is the metabolite detected which will help in suspicion, confirm the suspicion. So answer is acetaldehyde. So answer 134 is option A, acetaldehyde. Now let us discuss briefly the metabolism of ethanol. This is the alcohol in the beverages. So it is metabolized, 20% of it is metabolized by the microsomal ethanol oxidizing system in the sarcoplasmic endoplasmic reticulum SER, which converts into acetaldehyde, while 80% of it is converted by the enzyme alcohol dehydrogenase into acetaldehyde, which is again converted by aldehyde dehydrogenase into acetyl CoA, this converts to fatty acid, and acetate is converted by the citric acid cycle to CO2 plus water. Now this acetaldehyde has a retention time in blood of around 7 to 10 hours, while in urine around 10 to 13 hours. So it may be, so detection of acetaldehyde may help to detect ethanol use in the person. So the answer is acetaldehyde. Now answer to question 135, that is, a male started consuming alcohol at 20 years. Now he complains that he gets a kick even in 1 quarter. So the diagnosis is, the answer is C, that is reverse tolerance. So let us discuss about the reverse tolerance. So this answer 135. Now reverse tolerance this question will include some of the important fundamentals of few of the important phenomena which generally seen in alcohol, may be seen with other substances, but especially alcohol. So let us discuss in detail. So it is also known as drug sensitization, which is opposite to drug tolerance or desensitization. Now what is it? Now here the subjects increased reaction to drug. Now the reaction may be positive or negative following its repeated use. Now for example, in alcohol, if chronic use, this may lead to liver damage. There is risk of intoxication because the alcohol may not be metabolized as fast as it was previously, so it may lead to intoxication events even with small amount, like in the question. So this is reverse tolerance. Now what is then tolerance? So it is the ability to tolerate higher doses of, or larger doses are required to get the effects. Tolerance may be three types. It may be behavioral tolerance, then it may be pharmacokinetic tolerance, and it may be pharmacodynamic or cellular tolerance, that is tolerance at the level of cellular functions. Behavioral tolerance, for example, even after chronic use, the person may be able to do certain behaviors like going out, walking, even like he is doing as before. So this is behavioral tolerance. Now, once the tolerance develop for one brain depressant, now it is likely to produce similar reactions to other drugs of the same class. So this is known as what we call as cross tolerance. So this is cross tolerance. Since alcohol is a depressant, so other depressants if we use, so they may show similar effect. So this is cross tolerance. Now important concept to understand is the Mellanby effect, also known as acute tolerance. So what is it? It is especially seen with alcohol. So now let us discuss what it is. Now, according to it, the behavioral impairment at a given blood level behavioral impairment at a given blood level is greater when blood level rises than falling. So what does it mean? Let us understand with the help of a graph. Suppose a person is consuming alcohol, this is the time and this is the blood alcohol concentration. So with time it says behavioral impairment at a given blood level greater when the falling in this pattern. So let us say at a given blood level, let us say an arbitrary level X, at this level, given level, both while at rising and at falling. So let us give it as A and B. So the behavioral impairment according to it at a given level is greater when the level is rising. So although the blood level is the same, but the behavioral impairment will be more at point B than point B, although the level is the same. So this is also known as acute tolerance. By the time it reaches level B, there is some development of tolerance. So behavioral impairment is not the same as it was before. So this is especially seen in alcohol. Now, question 136, which one opioid medication can be used to treat some of the symptoms of opioid withdrawal? So the answer is D, clonidine. So let us discuss the question 136. Answer is D, clonidine. Now let us discuss the management of opioid withdrawal or the opioid withdrawal treatment. Now it may be with the help of opioid agents and with the help of non-opioid agents. Now, various opioid agents which are used in the withdrawal states are methadone, then buprenorphine, which is a partial agonist, then LAAM, which is levo alpha acetyl methadol. Now this is not used because of the cardiac effects. Also another one is the tramadol. Now important non-opioid agents which may be used for the treatment include, first is the alpha 2 agonist in the form of clonidine, then also lofexidine. These may be used. Now the withdrawal symptoms they decrease sweating, cramps, nausea, vomiting, diarrhea. Generally have less helpful for insomnia, then muscle aches and craving. So these are, especially clonidine is very widely used for the withdrawal symptoms. Now few important techniques used for the detoxification is the first is the rapid detoxification. So if the question comes, then rapid detoxification used for opioid withdrawal. Now here for the management of acute phase, is decreased using antagonists. So for the decreasing the acute phase of management, antagonist is used. So this basically decreases the period of hospitalization. What is done here is naltrexone is used, which is an antagonist, opioid antagonist, to precipitate withdrawals. Along with the withdrawal symptoms are treated with supportive management as well as drugs like clonidine. So there is rapid detoxification. Then another important point is the ultra rapid detoxification. Now what is done here in ultra rapid detoxification is, here now even large doses of antagonist are used, but they are used under general anesthesia to decrease the withdrawal syndrome. So under GA, that is used to decrease the withdrawal syndrome, but they are done again in ICU setting, so there is some risk is involved, risks are present. So if asked that these techniques are used for which substance, so you'll mark opioid withdrawals, rapid detoxification and ultra rapid detoxification. Now let us discuss the next question. A 38-year-old woman with bipolar disorder has been stabilized on lithium. She comes to a psychiatrist office 2 weeks of depressive symptoms, poor concentration, then there are depressive symptoms present. So which step should be the psychiatrist next take? Now since the person is already already a case of bipolar disorder with depression. So the answer to 137, the answer is option D. That is, you need to start the person on an antidepressant, along with you need to continue lithium. Why lithium? Because since this is a case of bipolar affective disorder and giving an antidepressant, there may be a chance of switch. So you need to give an antidepressant under the cover of a mood stabilizer. Now, and since here the patient was stable on lithium, so we may continue lithium, and we need to regularly monitor lithium levels as well, and if required then another mood stabilizer may be added for the symptom management. So the answer will be option D. Now question 138, what is double depression? Now double depression, the correct answer here will be option C, that is major depression or on neurotic depression. As we discussed, neurotic depression, also sometimes dysthymia is known as neurotic depression, so it's a major depression on neurotic depression. Now we'll discuss both 138 and 139 together. So in 39, identify the mental health disorder. Now here there are episodes of depression and mania occurring, so the answer will be here option C, that is bipolar mood disorder. So let us now discuss how diagrammatically we may discuss, and we'll discuss how we can diagnose with these graphs. So after question 138 and 139 we'll discuss together. So now if we plot a graph, now this is the normal mood. Now this is depression and upwards is mania. So let us discuss. Suppose this is a subsyndromal depression. This is hypomania and this is mania. This is hypomania and this is a depressive episode. Now for a single episode of depression, so this will be a single episode of depression as described. Now if there is another episode, so this may be known as recurrent depressive disorder. Now similarly, let us see if again this is subsyndromal depression, this is a depressive episode, this is for hypomania and this is for a manic episode. Now suppose there is a subsyndromal depression or neurotic depression and subsequently there is an episode of depressive episode. So this is what we are called as double depression. So a major depressive episode which is followed initially preceded by a dysthymic period, dysthymia. This is double depression. Now, let us again see few more of such diagrams. Suppose there is an episode of depression and subsequently followed by an episode of hypomania. So this is bipolar affective disorder, and depression with hypomania, this is in fact bipolar 2. And if it is not a hypomanic episode, let us discuss in another diagrams. Now if it is if there is depressive episode and there is an episode of mania, so this is known as BPAD, bipolar affective disorder 1. Okay. Similarly, if for, let us say, for 2 years period there is mostly low dysthymic level of depressive episode, maybe 1 or 2 short period of mild depression, if they continue for 2 years, so this is what we known as persistent mood disorder as dysthymia. Now, similarly, if again for a time duration of 2 years there is fluctuations between dysthymia and hypomania may be there, so this is known as cyclothymia. Similarly, now if for a 1 year duration there are periods of depression or hypomania or mania, depression, and these are at least 1, 2, 3 or 4 such episodes have occurred, so this is what we known as rapid cycling. So through these diagrams we have discussed mostly all the mood disorders which we can describe by these diagrams. So these may be prospective visual based questions, so which we need to remember. Now a 40-year in question 140, every 4 to 5 weeks a usually well functioning mild mannered 35-year-old female experiences days of irritable fearlessness, unexplained sadness. She is also fatigued, bloated, so there are physical symptoms. She also is eating more. So what is the appropriate diagnosis? So the correct answer is premenstrual dysphoric disorder. Let us discuss the in detail question 140. PMDD, premenstrual dysphoric disorder. Now previously this was in the appendix, but in DSM-5, in DSM-4 it was in the appendix. It has been brought to the main body of the diagnostic system. So this is important. This is a change in the DSM-5. Now, how now to diagnose DSM-5 in premenstrual dysphoric disorder? Now, in majority of menstrual cycle, the symptoms they are present in the final week before the onset of menses. Important to remember, before the onset of menses these begin, the symptoms begin and they start to improve within few days of the onset, and they are minimum or absent in the week post menses. So they occur in the final week before the onset, start to improve within the few days of onset of menses, and in the post menses week they are generally minimum or absent. So now 5 of the following symptoms should be present. Now these symptoms include affective lability, then irritability, then depressive mood, marked anxiety, then decrease interest, lethargy, decrease concentration, decrease or increase in the appetite, then there is decrease or increase of sleep, then there is behavior of being out of control, and there may be physical symptoms. So out of these 5 symptoms should be present, and at least of the 5, at least one must be from these 4 and rest may be from the remaining. So for this we say it is a premenstrual dysphoric disorder. So you may not remember all the symptoms, but you should have a overall view of what all symptoms are generally present, especially mood symptoms are very important. Now we need to then differentiate it from options like premenstrual syndrome. Now here there is no requirement of any 5 symptoms. Now this is less severe and this is more common. Also, what important are here are the physical or the behavioral symptoms, which and plus minus they may or may not have affective symptoms. So this is how we differentiate it from premenstrual syndrome. Another important differential diagnosis for this would be dysmenorrhea. Again, dysmenorrhea is in fact painful menses, and they generally begin with the onset of menses, unlike PMDD which occurs before the onset of menses. So this may help to distinguish. Again, it is important as it is a new entity in DSM-5, so we need to be aware of it. Now let us discuss the next question. So answer 141, which is incorrect about the clinical findings shown. So answer D, that is seen in catatonic schizophrenia. No, it is not seen in catatonic schizophrenia. So let us discuss question 141. Now let us discuss various signs seen in depression. Although they are not pathognomic, but they generally maybe help in the better diagnosis of the patient. Now there are psychomotor disturbances. There are psychomotor disturbances which are abnormalities in the motor expression of mental and emotional activity. So abnormalities in the motor expression. So there are abnormalities in the motor expression may be seen. So one of the first important signs which we will discuss is the Varigut's fold. Now it was given by a Swiss gentleman with the name of Otto Varigut. Now he described a peculiar triangle. Shaped fold now in the nasal corner of upper eyelid. Now there is a peculiar triangular shaped fold in the nasal corner which was between the inner and the at the junction of the inner one third and the middle one third upper eyelid, which was upwards and backwards. So a triangular fold described. Now this is basically because of distinct changes in the tone of corrugator and zygomatic facial muscles. So this is known as autovergus or the vergus fold. Now another important sign is the omega sign, which was described by Athanasio Now he described a Greek omega fold, Greek shaped omega fold on the forehead, just above the root of the nose. So just above the root of the nose there is a omega shaped fold. This is because of the excessive action of the corrugator muscle. So again, important to remember. So two important characteristic signs are the vergus fold and the omega sign. These are generally seen in depression. Now, all of the following are important factors for suicide, potential risk factors. So the answer is C, being married with 3 children. These are in fact, they prevent these factors in fact prevent for suicide. So let us discuss various high risk factors for suicide. Question 142. So the answer is C. Now let us discuss the high risk factors for suicide. Now, first let us discuss the demographic factors. Various demographic factors which include age more than 45 years, male, then divorced or widowed, unemployed, then health factors, various health factors including history of any chronic illness, comorbid psychiatric illnesses in the form of depression, psychosis, substance use disorders, then suicidal activities, including there is frequent suicidal ideations, history of suicidal attempt, again this is a high suicide risk factor, history of suicide attempt, then planned, the person has planned the activity, and also if the escape or rescue is unlikely, suppose any method which the person has chosen, so in which the escape is less likely, so that again these are high risk factors. Then other are the resources. For example, poor insight, then poor achievement, there we will able to not have a good rapport, a poor rapport, there is poor social support. So while in the option a married person with 3 children, it's a good social support, seems to be good social support. Socially isolated. Now also a person with sudden improvement, who was hopeless or helpless. This may again be a sign that they may be suicide attempt, maybe in the near future. So you should be very vigilant about such patients. So these all are important high risk factors for suicide. Let us discuss the next question. Which of the following is not a cognitive dysfunction? Now, as we have discussed, that thought block is a disorder of the thought, so it's not a cognitive dysfunction. Now let us discuss how this question has been framed. Now basically, 143 is option A, thought block. Now this question is based on the cognitive theory of depression. Cognitive theory of depression, which is given by Aaron Beck. Important. Now, according to this theory, depression results from specific cognitive distortions. Some of the important cognitive distortions which he described include, there are many, but some of the important ones include, first is arbitrary inference, that a person makes an arbitrary inference of whatever thing is, a situation is there, and specific abstractions may be made. Then overgeneralization, he may overgeneralize every situation, every event occurring, like everyone is, if one person has done something, so every person is bad. So this is how overgeneralized. So these are cognitive distortions. Then catastrophizing. So here the person expect disaster to occur, no matter what. This may be magnification or minimization. Then there may be personalization, that is everything which is occurring, a person assumes to be is being for him, anything bad is occurring, it is for him. Then there is absolutist or dichotomous thinking, that is, if person, he may say that one person is good, it's good or bad, he may not be able to appreciate both the qualities in a person, so it is either black or white. Now also Aaron Beck or Beck has also given Beck's cognitive triad of depression, which is negative view of self, negative view of environment, and negative view of future. Now, negative view of the self may be described as the negative view of the self, negative view of the environment, and negative view of the future. Or negative view of the self may be described as being worthlessness, negative of the future as helplessness, and negative of the future as hopelessness. Now the cognitive behavior therapy which is used, basically it consists of modifying these distortions which is just discussed. So this is why we use cognitive behavior therapy for treatment of depression. Now, according to the current clinical guidelines for treatment of bipolar 1 disorder, mania with psychotic symptoms, best treatment option would be, the answer would be here is answer D, that is quetiapine. Let us discuss in brief about the management of the, so our question 144 option is D, quetiapine. Now for treatment of mania, the first step is to, if there is any drug being, we need to first find out the patient is taking any drug. If yes, and if there is an antidepressant the person is taking, we need to stop antidepressant. This is the first step which you follow. So if the question is saying the person has some antidepressant, say sertraline, so the first step would be to stop the antidepressant, and then if the person is not taking any other medication, like mood stabilizer, if he is not taking any other medication, so now the first step would be to use antipsychotic, especially when their symptoms are severe or the behavior is disturbed. Now especially in this case, since it is mania with psychotic symptom severity is very high, so we may use antipsychotics. Now so antipsychotics which are generally used are olanzapine, risperidone, quetiapine, then aripiprazole, acinapine. These are the important drugs which may be used as per the current guidelines. Now especially quetiapine, it has a robust activity. It has a robust activity in generally all the aspects of bipolar disorder, vis-a-vis let us say mania or depression, or even in the maintenance phase. It has a good robust activity in all the various phases of bipolar disorder, so it is a important drug. Now we may if antipsychotics, or first we may use antipsychotic, or lithium may be used. Now if adherence, especially if adherence is likely, that is if we are sure that the person will continue to be adherent to the medication, so in place of antipsychotic lithium may be used, or we may even use valproate, but it should be avoided in females with child bearing age, females with age group we should avoid. And also, now if the response is inadequate with any of these, then antipsychotics may be combined with lithium or valproate. Also, we may consider benzodiazepine like lorazepam or clonazepam for short term in the acute phase along with the above medication. So, benzodiazepine may be used. Now, let us go to the next question. A 35-year-old man is diagnosed with major depression and started on sertraline 25 mg. After 1 week, the dose increased to 50, but the person may remain depressed. So, what is the next line or the most appropriate next step? Now, again, it is very important for the management of a depressive episode. So, the correct answer here would be option C. That is, we need to increase sertraline. Now, let us see why. Question 145. Now, management of a depressive episode. Now, we need to understand what is an adequate trial. Adequate trial of an antidepressant is basically, it says that to say a drug is effective or ineffective, the drug should be given for at least 4 to 6 weeks with usual dosage. That is, we should give at least 4 to 6 weeks of trial of a drug at a usual dose before labeling it as a drug as effective or ineffective. Now, some of the important usual dosages for the drugs: sertraline, fluoxetine, escitalopram, paroxetine, fluvoxamine, then bupropion, venlafaxine, duloxetine, and mirtazapine. So, we will just discuss usual dosages in briefly about these drugs. So, the SSRI group of drugs including sertraline, the usual dose is 50 to 200 milligram per day. So, 50 to 200 milligram per day. Then for fluoxetine it is 20 to 80, escitalopram it is 10 to 20 milligram per day, paroxetine it is 20 to 60, and fluoxamine is 50 to 300 milligram per day. For bupropion it is 150 to 450 milligram per day. Venlafaxine it is 75 to 300 milligram per day. Duloxetine it is 20 to 60 milligram per day, and for mirtazapine it is 15 to 45 milligrams per day. So, these are the usual doses. So, for at least 4 to 6 weeks on usual doses, only then we can say that the drug is effective or ineffective. So, the answer to that question was we need to increase the dose of sertraline. So, this was the answer. Now, let us discuss the next question. Now, which of the following is more common in males and the first born child? Now, out of the given options, the correct answer is option C, OCD. Now, let us discuss more things in detail. Now, OCD, obsessions. What are obsessions? Now, obsessions are recurrent and intrusive these are recurrent and intrusive thoughts, images, impulses which are distressing to the patient, and he also tries to resist them. He acknowledges them as his own but is unable to resist successfully. So these are obsessions. Now, as we had already discussed, obsession is a disorder of possession of thought. Possession of thought, and they are ego dystonic. Now, similarly, compulsions are repetitive actions. They may be mental actions which the person has to repeat. They again are distressing. Now, the OCD, obsessive compulsive symptoms, obsessions and compulsions, they may be seen in OCD, they may also be seen in depression, they also may be seen in schizophrenia, as well as may be seen in even some organic states. Now, also nowadays questions being asked about what are the most common obsessions and compulsions. So let us just discuss, because they've recently also been asked. So now, most common obsession is the contamination. Then second most common is pathological doubt. So if contamination is not in the option and you're asked the most common, then it becomes the most common. If the contamination is not in the options. Then third, somatic. Fourth, need for symmetry. Then fifth, aggressive, intrusive thoughts. Sixth is sexual intrusive thoughts. And seventh is the other. Similarly, let us discuss the most common compulsions. Most common compulsion is checking. So C for contamination, C for checking. So these are the most common reception and most common compulsion. Then washing. Washing is the second most common. Then third is counting. Then fourth is need to ask or confess. Then fifth is symmetry. Then sixth is hoarding. And seventh is multiple compulsions occurring together. So we need to again remember, as this was a recently asked MCQ, so you need to remember at least the top three obsessions and compulsions. So answer question 147 is again irresistible urge to do a thing repeatedly is seen in obsessive compulsive disorder, as we had just explained. Now let us discuss the next question. Concept of pandas is related to, again it is related to OCD, that is obsessive compulsive disorder. Now let us discuss. So answer to 148 is option A, OCD. Now, so what is pandas? Now pandas stands for pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. So this is pandas for you. Now according to Lombroso and Scahill in 2008 they gave some criteria to diagnose pandas. So few important are the criteria includes presence of tic disorder and or OCD, then pre-pubertal age of onset, it should be before puberty, then episodic course, then there is temporal association with group A beta hemolytic streptococci and also adventitious movements during the symptom exacerbations. So these are the important criteria which are described for the diagnosis of pandas. Now, what is the hypothesis that how it is etiology of the hypothesis for the etiologies of panda? Now there is a proposed link. It is proposed that initial autoimmune reaction to group A beta hemolytic streptococcus infection it produces antibodies which subsequently interfere with basal ganglia function and subsequently leading to the production of symptoms. Now also you need to remember that pandas may account for substantial cases of childhood onset OCD and related disorders. So it may account for a lot of these cases. So it is especially in the pre-pubertal age group we should be highly vigilant for the same. Now let us discuss the next question. So which of the following is not a somatoform disorder? So again the answer is B, OCD. Now very important question, as a lot of changes have been made in the diagnosis in the various categories which are put in somatoform disorder. So we need to discuss. So the option is option B, OCD is not a part of somatoform disorder. Now somatoform disorder, what are somatoform disorders? Now in the somatoform disorder there is prominence of somatic symptoms which are associated with significant distress and impairment. Now DSM-5 now has changed the name somatoform disorder as somatic symptom and related disorders. This is the new entity which is used by the DSM-5. So what all various syndromes or disorders are discussed in it? Let us see one by one. First is the somatization disorder. Now again, the name of this has been changed in DSM-5. The name in DSM-5 is now somatic symptom disorder. So somatization disorder now in DSM-5 is known as somatic symptom disorder. Now what it is, let us discuss in briefly. Now there are multiple frequent, recurrent, changing physical symptoms and no cause is able, we are not able to find any cause, but they are multiple, like sometimes pain in the legs, pain in the upper body, pain in the mouth. So there are frequent changing complaints, various systems like respiratory, abdominal, genitourinary systems, these are involved, but we are not able to get a cause for it. So this is somatization disorder, also known as, in literature it is also known as Briquet syndrome. Now second, after somatization disorder or the somatic symptom disorder in DSM-5, the second is the hypochondriacal disorder. Again, it is new term is given in DSM-5. It is known as the illness anxiety disorder. In this, there is a preoccupation of having or acquiring a serious illness. For example, a patient having pain abdomen may say that I am having cancer. So it will be, and he will be preoccupied with this complaint. There is one or two particular complaints, but he will be reporting that he has acquired or is having some serious illness like cancer or any other serious illness, despite being proved. So hypochondriacal disorder, there will be preoccupations. Then third important is the conversion disorder. Again in DSM-5, it is known as functional neurological symptom disorder. Now here there will be one or more symptom of altered voluntary motor, or sensory function. For example, the person may report of weakness in the limbs or paralysis or seizure-like activity may be there, or swelling symptoms, swallowing symptoms may be there, or there may be sensory loss may be there. So these are the symptoms which may be present. Now fourth important one is the factitious disorder. Now, earlier in DSM-5 it was a separate diagnosis, but now it is described under somatic symptom and related disorder. Here the person may simulate or induce or aggravate illness, but the purpose is to receive medical attention or to assume sick role. So this is factitious disorder. Now other is the fifth important is in the somatic symptom and related disorder. Fifth category is the psychological factors affecting other medical condition. Now these are currently in the DSM-5. These are the criteria which are disorders which are under somatic symptom and related disorder. Now, but why again in the option also we have body dysmorphic disorder. So why we are not saying that it is the answer? Because previously in DSM-4 under somatoform disorders or the somatic disorders, there was also pain disorder, which is again preoccupations with pain despite no evidence of any cause, and body dysmorphic disorder. It was also previously in the somatoform disorder in DSM-4. So we are saying that it is OCD, which is not a somatoform disorder. Now in DSM-5 obsessive compulsive and related disorders include some of the following disorders, which are: first is OCD, second is the body dysmorphic disorder, then third is the hoarding disorder, then fourth is the trichotillomania, and fifth is the excoriation disorder or the skin pricking disorder. Skin pricking disorder. So these are the important disorders which are now in OCD and related disorders in DSM-5. Now let us discuss the next question, kleptomania. Now answer is, it's an irresistible desire to steal things. Answer is A. Now, let us discuss briefly about kleptomania. Now it is seen in ICD-10. It is described under habit and impulse control disorders. Now here it is male is to female ratio is around 1:3. Now here the stealing, the desire to steal or the stealing, it is generally not planned and not needed for personal use. It is not needed for the thing which the person is planning or is stealing, is not required for personal use or for monetary value. And also the act of stealing is the goal rather than the thing which is stole. So this is important about kleptomania.